Hello, and thank you for joining us at the 13th Annual Joining Forces Against Hereditary Cancer Conference. We are so excited that we are able to come together again virtually this year, and that you are attending our panel discussion on genes associated with hereditary cancer risk. The topics covered today are paramount to our community. The power of force improves the lives of millions of individuals and families facing hereditary breast, ovarian, pancreatic, prostate, colorectal, and endometrial cancers. Our community includes people with a personal or family history of cancer and inherited gene mutations linked to cancer. The FORCE mission is accomplished through education, support, advocacy, and research efforts. During and after the conference, be sure to access individual session resources, visit the exhibit hall to engage with sponsors and download their resources, and use the attendee tab to network with conference attendees. We also want to hear your feedback on our sessions and our overall conference, so please make sure to access our session surveys found in the resource section for each individual session. My name is Elise Boucher. I am a previvor with a BRCA1 mutation and a member of the FORCE community. I am going to be your moderator for this discussion. At this time, I would like to introduce our panelists. Dr. Tuya Pal is a professor of medicine and an Ingram Professor of Cancer Research at the Vanderbilt University Medical Center, where she is also the Associate Director for Cancer Health Disparities at the Vanderbilt Ingram Cancer Center. Her research has focused on inherited cancer risks across basic and clinical services, as well as health services delivery, including efforts in underserved populations. Dr. Marc Tischkowitz is a professor of medical genetics and honorary consultant in the Department of Medical Genetics at Cambridge. Much of his research has been on the Fanconi anemia genes and hereditary breast cancer predisposition, but his interests cover all areas of hereditary cancer and translating the recent advances in genomic technology into clinical practice. Julie Mack has been a clinical genetic counselor since 2002. She works with patients investigating all types of hereditary cancer, with a special focus on breast and gynecological cancers. She is a clinical supervisor in the UCSF Hereditary Cancer Clinic, an interdisciplinary program providing care to people who have inherited pathogenic variant associated with increased risk for cancer. We have received many questions over the past couple of weeks that have been pre-submitted by all of our attendees, and we already have a number of questions in our chat, so thank you so much for your engagement here. We are going to kick it off right now, and I'm going to pose the first question to Julie. We had a constituent write in, I recently had genetic testing through an at-home testing service. The results referenced variants in BRCA1, BRCA2, and some other genes that I didn't recognize. I don't understand what this means for me and my risk. What should I do?
So thanks so much for asking. I know there are so many tests out there now that people are accessing, and that's, I think, sort of got two sides to it, because it can be pretty alarming to get information and not have the context. I can't comment on the report specifically without seeing it, because, as I said, there's so many different tests. I want to say that first, to emphasize that it's unlikely that all of those things are going to be clinically important. But check with the lab that did your test. Maybe they have genetic counselors that you could speak to. And certainly there are clinical genetic counselors working in, like myself, working in medical centers that could take a look at that report, let you know if it's valid, because sometimes people come to us with reports they've done at home that we don't think are that reliable, and we might suggest a different test. But if it is a reliable test, then we can help you interpret it and connect you to what you need. And a lot of genetic counselors now, if you don't live close to one, you can access something through video. So definitely I would say talk to the lab that you did the test at and try to get into somewhere where there's some clinical services to help you look at the test. But until then, I would also say just, you don't have to jump to the conclusion that all of those things are important. It's rare for us to get a report where there's, many different high risk things on it.
Thank
Good
you.
luck.
Thank you. That's a very comprehensive answer. And so
Hi,
I do.
can I,
Oh, Go ahead.
I just to add to that, Julie, I completely agree with everything Julie said. The other thing is, like, when we're talking about variants, there's, is it a variant of uncertain significance versus is it a pathogenic or likely pathogenic variant? Again, all variants don't mean that they cause disease. Some of them we don't know enough, and many times they'll end up being nothing. And speaking to Julie's point about the labs, there have been studies that have been done where some of these at-home tests, if you get them like the raw data reinterpreted, most of those results will end up being wrong. So again, we're just kind of putting it into context. When we're thinking about the population frequency, in European ancestry individuals, for BRCA1 and 2, it's, somewhere around 1 in 500. So if you keep multiplying that and thinking about all these variants that you're seeing, it's pretty unlikely that you're going to have mutations in all of them. So again, I think I would feel very strongly about going to see a clinical person with expertise in this, like a genetic counselor. And NSGC makes it really easy. It's findageneticcounselor.com, and you can search by zip code.
So that brings up a very valid point, and this is something that one of our constituents wrote in about, because a lot of times there can be a cost barrier for people when they want to go for genetic testing or when they want to go for a consultation with a genetic counselor. Tuya or Julie, can you speak to any low cost or no cost testing options that are you would receive your results from a reliable lab and a reliable source?
Julie, do you want to take that and then I can add?
Sure. I absolutely know that that's on a lot of people's minds. One of the first things I want to say is I think that there's been improvements, I think, in insurance coverage of genetic counseling, genetic testing. So sometimes the thing that people remember, people come to me and say, 10 years ago, I tried to do this and it was like cost prohibitive. So knowing that has changed, and I still think that, of course, I'm biased. Tuya and I work at academic medical centers and we see patients there. And so, we're a little bit biased in saying, I think you're going to get your best care if you go talk to an expert who does this. So I do want you to know that may be an option that is covered by your insurance. It isn't always out of pocket. But for people who don't have insurance, which unfortunately I know happens for people with insurance where they have really high deductibles, some people, they know there's something in their family and they're like, I'm not that worried about it. I just need the information first, and then I'm going to go from there because I've been hearing about this for 5 years. There are more and more good options. I know that Force, on your website, there are some resources that we can direct people to. We talk about some of the labs. If you have a family member who's tested positive, you get a discount. I'm not sure if you want me to be naming specific companies because I'm not sure if this is the right forum, but there are a few reliable laboratories where you can get low cost testing, and we do direct people to them when that seems like the right thing. And so I think contacting Force, looking at the National Society of Genetic Counselors, you can get directed to some reliable resources. I will just throw out some numbers there that in some cases, testing could be free or $50 or $250. So very different from the thousands that people heard about, in the past.
Yeah, and just before you touch base there, I do just want to speak to the specific resources that you just brought up. If you go to the Force website, specifically under and search for paying for care, that is the section that you want to go to really find more information and everything that Julie was just talking about. Go ahead, Tuya.
Yeah, no, I was going to reiterate that Force has some amazing resources. So this is something that many patients who are interested in testing are concerned about. And, I'll tell you, Elise, those Force resources, to me, that is where we direct them from our research side, because you guys do such a great job with keeping it current, accurate, unbiased in terms of inclusivity for labs. And just like Julie was saying, the commercial labs actually have very generous financial assistance plans at the end of the day. So most people who are eligible for testing based on NCCN guidelines will be able to get testing at reduced or no charge, depending on ability to pay if you don't have insurance. Now, for the genetic counseling, like Julie was saying, most of this, like this service is covered for the most part. And we actually just conducted a study. One of my mentees, Maya Roberson, published a paper in JAMA Network Open within the last month or two, where she showed through a very large data set that out-of-pocket expense for genetic counseling on average was zero for an insured population. So again, I think the main thing here is getting to someone who can assess your risk and get you the testing that you need if you're interested. And, you know, back in the day, 2013, I guess, when the BRCA genes were patented, in the US, it cost over $4,000 to get BRCA1 and BRCA2 testing. So thinking of that versus today, like Julie said, the cost is $250 self-pay if you don't have insurance, and we can get 80 plus genes covered. So the cost is really plummeted. Again, $250 is still a lot of money, but it's not thousands of dollars for each gene anymore. But again, when you do the testing, you also need to be prepared for the results. So I would caution use of these large panels without having the context of genetic counseling in there.
So you just said something that is a good segue into our next question, talking about panels that can test for up to 80 plus genetic mutations. And I'm going to pose this next question to you, Marc. So we have a constituent here who did panel testing about 5 years ago in 2017, and it was all negative. But they don't feel reassured by those results at this point. There's never been a mutation found in their family, but they do have a strong family history of breast cancer at a young age. Are there any new genes that they should be testing for? Should they go for genetic testing now that they're at that 5-year point to see if there are panels that are more comprehensive? What is the advice that you could give to this constituent?
Yeah, thank you, Elise. That's a good question. I'll start off by saying that 5 years isn't that long ago. So I imagine that whatever testing was done then would be fairly similar to what we offer now. We have looked very hard for other genes that cause breast cancer, new genes, and we haven't found any that are going to be common. So I think we're really left very much with what we've got in terms of the strong acting genes like BRCA1, BRCA2, PALB2. So there isn't. We know for sure there isn't going to be another gene out there that we're missing that is equivalent to those types of genes. We've looked, the whole global research community has looked for a long time. So I think that's quite reassuring, but it still leaves the question as to what is the cause of the cancers in many families, and for many remained unexplained. And there could be some of the explanation could be that perhaps the wrong person was tested in the family. So if it's a truly strong family, it might be worth having a think about, and if only one person's been tested, it might be worth thinking about, should someone else in the family be tested, someone else who's had young onset breast cancer or a related cancer. Because sometimes that can shed light on things, because the complicated thing is that, the cancers that we're talking about are often quite common in the general population anyway. So in a family, you often do see, cancers mixed in that have been caused by chance, as well as those that have been caused by genetic predisposition. So I think that's one thing to think about. I think it's worth a discussion with the genetics team, with your genetic counsellor, and to recontact them. Certainly, the patients that I see when I write my letters, I always say, please contact us again in a few years' time for an update. And that's particularly true if there's something new in the family, something that's changed, so a new cancer diagnosis, for example. Another area where we think, some of these families might be explained is that of polygenic risk. So, and that's really, we talked about that a bit in the presentations, but that's really moving away from these strong acting genes and thinking about the hundreds of little genetic modifiers that individually will all give us a risk estimate, varying from the general population up to high risk. So some of these families will be explained by that, and that's something that is coming along. it's probably not quite ready yet for prime time, but it is. I know some centres are offering it, and we're still exploring how it best works in practice. And that is something that's going to be on the horizon. That will solve some of these cases as well.
So I think you've really started to speak to something that a lot of our constituents are working through, consistently, and that is kind of this level of family dynamics. So when there is a history of cancer, who in the family is testing, who is not, what types of emotions does that bring up? Julie, we have a question from you from one of our constituents who's saying, how do you deal with family members who do not take the same precautions as you? For instance, this constituent doesn't have kids, but her sister has young adult children and they will not get tested. She's worried for them and wondering kind of what approach she should take in having these types of conversations with her family members.
Thanks, Elise. And I think you set that up really well, just to say that this is, it's not, I often say, if we were talking about genetics on a genetics exam, this is what I would say. But when I say to people, I know you don't live in a genetics textbook, you live in the real world. I know it's tough. I am hearing in that question someone who's really worried about their family members and wants to take good care of them. There isn't a single answer because every family is different, but some of the things that I think about are time. So we see that sometimes when there is a mutation or what we call a pathogenic variant identified in a family, there might be sort of a wave of people who run out and act on it right away and a wave of people who don't. Sometimes it is worth circling back to those people. They needed a little more time for things to soak in. I will also say I've seen that for some of those people who have, they're just not as familiar, or they're more scared, or they have just a different mindset. Sometimes that really strong advocacy isn't the most effective. One of the families that really sticks in my head is a young woman I saw who was diagnosed with triple negative breast cancer, who was BRCA1 positive. And she said, she and her sister both said, our cousins told us about this a few years ago. And she called us up and she said, I found this thing and I had double mastectomies, I had my ovaries out. You guys have got to do this. And it was just so overwhelming to them that they thought, we don't want to do what our cousin did. And they just ignored the whole thing. And so I think sometimes recognizing that everybody's going to receive this a little differently, and letting them know that there are things that they can do with this information. Absolutely. I think risk reducing surgeries are the right choice for lots of people. They're recommended in a lot of cases, but making sure that your family member knows that this information is still useful to them, even if they aren't prepared to think about those surgeries, to think about getting some extra screening. So I think taking sometimes a softer stance actually, I think, can reach more people. Thinking about who are the trusted people in this family. Sometimes there's just that person that everybody goes to, and leveraging their help. And finally, this is a very delicate thing, but I think this question involved sort of saying that this person's sister's children, they're worried about their children. And I think depending on the age of their children, if they're adults, so if they're, in their 20s, 30s, 40s, sometimes again, every family is different. I wouldn't want to, create any more problems with family, but sometimes it makes sense to talk to your nephew and niece directly, because their parent doesn't want to be tested. Again, you have to think about, is that going to make my relationship worse? If my nephew or niece tests positive, is that, going to reveal that to my sister that she's positive? And so it's not an easy path, but it's also something where, I think once they're older, we are careful about not wanting family members to lose out on information. So that's very individual to families. I said I wouldn't want to suggest something that makes the family dynamic worse, but just being aware that sometimes you do end up going to indirectly to people in the family, but only when they're older and only when you think that it's the right balance.
So I think that's such a comprehensive and relatable answer for so many of our attendees here today, myself included. So thank you for walking us really through that, and giving us resources and tools for feeling like we can feel confident in having those conversations. So I think now let's take it a step further. I'm going to pose this question to you, Tuya. If there is a family who has undergone testing like this specific constituent who wrote in. Both her and her sister have had genetic testing. They learned that they had a CHEK2 mutation from their mother who had breast cancer at 50, but they see different providers. They see different doctors. She's 33 and her sister is 36. She has not started her screening yet, and her doctor has not recommended to begin screening until the age of 40. However, her sister's doctor has recommended that she begin screening now. Can you speak to why there might be a difference here in what providers are recommending relative to their risk?
So I think this is very provider dependent. And I also think this is very guideline dependent, right? Guidelines evolve over time. And I'll tell you, the new NCCN guidelines were just released September 7th, 2022, right? So just a month ago. So prior to, like the guideline prior to September 7th, we said start screening age 40 annually with breast MRI and mammogram. But we reduced the age to 30 to 35 in this newly released guideline, again, based on research information that told us, based on some modeling studies, if we start earlier, what these modeling data tell us is that you can cut the death rate in half. And again, we're going with the best data out there currently, and that could evolve further. But that's where I think it's really hard for depending on the providers, those at academic centers that are already part of NCCN are going to know as guidelines change. But there's many providers out there, and I can't really fault them because guidelines are changing every year. So just making sure you are seeing someone that is familiar with evolving guidelines. I think patients themselves can empower themselves as well. There are, like, the NCCN guidelines are available to anyone who wants them, right? So you create a free username and password on nccn.org, and you can look up the guidelines for yourself. And in the breast, ovarian, pancreatic guideline, the genetics familial breast, ovarian, pancreatic guideline, you can see what is recommended nationally for CHEK2. The other piece I'll say, now that we're on this CHEK2 topic, is all mutations are not equal either. And that is where we're headed with, and again, I'm going to try and simplify this, but truncating versus missense. Truncating means the protein becomes shorter versus missense is kind of a spelling change, but the protein is still the same length. So truncating mutations tend to be more severe. So the risks may be higher. There is one missense mutation, the I157T mutation in the CHEK2 gene that raises the risk by 1.3-fold. That is not a big number, and that doesn't even raise the breast cancer risk by 20%, like lifetime risk to 20%. That is a founder mutation. So again, in countries outside of the US, they don't even report this variant out as something that's reportable on germline testing or tumor testing, right? So I think it's really, really important to go to a provider who is knowledgeable and to empower yourself about, okay, what is the new information that is coming out? Joining organizations like Force, where you all are pushing out information on a regular basis. That's what I would say. I think with CHEK2, right now, per current guidelines, it would be 30 to 35. Starting the MRI, the mammogram start at age 40, but that is modified by family history. I do think that there is a consideration to modify based on mutations, that specific mutation that I mentioned. And then polygenic risk scores are coming down the road, right? Like Marc already mentioned. And I do think that is going to be a risk modifier, because we know already that, there are going to be many folks that don't have a 20% lifetime risk of breast cancer. And there's many people that are going to have much higher risk, because the spread is pretty large for CHEK2. So I think the polygenic risk scores, as they become available, are an area where we will be able to refine risks a lot better than what we are able to do now. And in Marc's talk, I think CanRisk was mentioned, and I think that is a phenomenal tool that is available currently to be able to refine risk. So I would encourage anyone that is interested to check it out. I think they've made, Marc, I noticed there have been some really great enhancements to it to make it pretty user-friendly at this point.
Yeah.
The one thing I will say with PRS, though, is we have to overlay that with Ancestry. And that becomes a problem, right? Because most of our data for polygenic risk scores is based on individuals of European ancestry. And that really sets us up for a disparity because we can make risk predictions a lot better in European ancestry individuals than African ancestry individuals or Asian ancestry individuals. So again, I do think there's a lot of promise, but there is work to do so that this type of technology doesn't widen existing disparities.
Could I just add to you that actually the guidelines will vary from one country to another as well. So, for example, in the UK, for someone who carries a Check 2 pathogenic variant, we wouldn't do anything until the age of 40, and then it would just be mammograms. So we're much more conservative, I think, in our approach, and that's partly because we work in a public health sector where economics, and economic benefit plays an important role as well. So there's a higher bar. So it varies, it will vary internationally as well. And just coming back to your point about CanRisk, definitely the way forward is going to be to give individualized risks to different people. So but that means that different people in the same family, for example, two sisters, will get different risks, even though they're carrying the same pathogenic variant and the same gene. And that's something that we will have to get used to. We are developing a patient-friendly CanRisk program that will be that will be coming out in the near future. So that will be even better for people to have a look at themselves, essentially. And I completely take your point about the limitations of polygenic risk at the moment as well. And that's a real challenge, and a lot of there's a lot of scientific interest and resource going into tackling that to make sure that we do have some equity in terms of how that can be used across people of different ancestry.
So, Marc, I think with all of this new information coming out about polygenic risk factors and how things are being labeled, it seems like it's ever evolving and it can change rather swiftly for somebody who is just a patient or seeking information. We have a constituent here who has a specific question in that, is PALB2 going to be relabeled as BRCA3, or will it follow the same guidelines as BRCA1 and 2 regarding breast cancer? And so this is a good question because it brings up if a mutation is relabeled or something takes on a new name and it falls into a bucket that we're familiar with, like a BRCA1 or 2 bucket, do then the guidelines translate for this mutation?
Yeah, so that's a good question. So PALB2 actually, it was originally identified because it works closely with BRCA2. So it's actually the partner and binder of BRCA2. And that's where the PALB2 name came from. And at the time, the researchers didn't realize it was going to be a breast cancer gene. Otherwise, they probably would have called it BRCA2. Trouble is, in the scientific community, once you've named something, once you've given something a specific a gene, a name, it's then very hard to change it, actually. So I think that at the moment that's unlikely to happen in the scientific literature. Now it may happen in outside of that, when people are talking about this in a public setting, in the press, for example, or something. But the guidelines will be quite specific for PALB2. So even if you change the name, we know all the data is still based on that gene. So changing the name to BRCA3 wouldn't then mean that you would end up with exactly the same guidelines that there are for BRCA1 and BRCA2. And you could then expand that argument and you could say, why isn't Check 2 called BRCA4 and ATM called BRCA5? So I guess the argument is where do you stop with that? And the other problem with the name of BRCA is that that's really focusing on breast cancer when we know that actually there are many other cancers, well, particularly ovarian cancer and pancreatic cancer, that may be associated with some of these genes as well. So even the BRCA name, even though it's well known, is incorrect as such. Just coming back to your point about risk assessment and how it might change, I think you're absolutely right that there are many different factors that can be included in risk assessment, not just polygenic risk score, which will change over time as we identify more genetic modifiers, but also things like breast density are a risk factor. And then there are some hormonal factors and then even things like alcohol intake slightly change your risk, essentially. So alcohol is a risk factor for breast cancer. It's not a big one, but it can slightly change your risk by a percent or two. So we may end up in a situation where you end up with a risk app that and the whole thing becomes more dynamic, where your risk does change as you get older, as your lifestyle changes, as you have children, as more polygenic, as the polygenic scores get better. So that creates a bit of uncertainty then, because we're not really dealing with just one number that you're going to carry throughout your life. It's going to be a more of a dynamic situation.
So can I just add to that, like even when we're thinking about BRCA1 and BRCA2, there are similarities, but they're not the same, right? So even within our guidelines, we differentiate certain care items across BRCA1 versus BRCA2. We know the male breast cancer risks are substantially higher in BRCA2. We know pancreatic and prostate cancer risks are higher in BRCA2. We also know that ovarian cancers on average tend to happen about 5 years later if they're going to happen. So the guidelines are tailored to they're not the exact same even now. So PALB2, and Marc has stated this before, yes, it's like a BRCA3 if there's ever going to be one, but it's a distant third, right? Because it's not at the same risk level as BRCA1 and BRCA2. It does have commonalities. It does reside in the same pathway. It's probably our data is telling us that even from a therapeutic standpoint, it functions in the same pathway. So treatments may have some similarities as well. Mainly what I mean by that is PARP inhibitors, right? Like there is data that's supporting that PALB2 associated cancers may also be susceptible to PARP inhibitors. So, all that to say with PALB2, yeah, there is ovarian cancer risk, but the risks are nowhere close to as high as what we see with BRCA1 and BRCA2.
So if we have someone, there's a number of constituents that are writing in with questions relative to BRCA1 and BRCA2 preventative measures. And Julie, you can probably speak to this as well. When you come in and you find out that you have that genetic mutation, it comes back positive on a result, you start to research preventative measures that can be taken. And so we do have a lot of people who are asking in the chat about the efficacy of removing ovaries or oophorectomy, and taking these risk-reducing surgeries into action when they do find out that they have genetic risk. Kind of where does somebody start when evaluating what surgeries they want to have, and what surgeries should they consider having and in any particular order?
Thank you for asking that question. I think I'm going to try to capture some of that, but I do want to emphasize, this is what all of your panelists here do on a daily or weekly basis. And we probably take, an hour with each person to really personalize that. So anything that I say, I don't think you can take off the shelf and apply. You really do need to talk to your doctors, talk to a geneticist or a genetic counselor to try to personalize that to yourself. I think, Marc and Tuya were just talking about BRCA1 and 2. I think most, or if not all of your constituents are well aware that the cancers that we are most alert to and most importantly kind of following are the risk of breast cancer and ovarian cancer in people who are, women assigned female at birth. So those are the things that we're focusing on. And then it really depends on age. And with BRCA1 versus BRCA2, as Tuya said, and personal history. So the breast cancer risk, sort of in terms of raw numbers, is higher than the ovarian cancer risk. And it is a cancer that can happen younger. So certainly if we're talking about people in their 20s and early 30s, the breast cancer risk is where most of our focus is going to be in terms of either screening or talking about preventive surgeries. The ovarian cancer risk is lower, but ovarian cancer is a cancer that we don't have good tools for doing any kind of early detection. We're not really great at treating it. We're getting better and better. So, we have hope, but I think that our recommendations, and this is something that does not change nationally or internationally, everybody agrees that people who are BRCA1 or 2 positive, who have ovaries, should consider having their ovaries removed when they're done having children or not planning on having children. With BRCA1, the recommended age is 35 to 40. With BRCA2, it's 40 to 45. So I think the answer to, what should you think about first depends on how old you are. If you're 50, I would probably say, and you've had normal mammograms and MRIs, we should be really prioritizing a discussion about removal of the ovaries for prevention. If you're 30 and you want to think about something preventive, your ovarian cancer risk isn't high at that age, and you want to think about a preventive surgery, then the conversation would be more about breast surgery. So it depends on lots of different factors. As I said, all of us spend hours plus with each person trying to figure that out. But those are some general guidelines to think about. How old are you? Is it BRCA1 or 2? What's the family history? And just know that there are people who can help you walk through this. It isn't something. I do want to say is it can be really overwhelming. And a lot of times I say this out, if anybody who's listening has been in a genetic counseling visit with me, it's completely authentic. I say this all the time. I say every week, I have to say out loud to myself, nothing magical happened when we did this test. If somebody was BRCA1 positive, they were already BRCA1 positive. And it can feel like this scary emergency if you're 38 or 42 and you just got this information. It feels like I need to run out and do all of these things tomorrow because I have this information now. And absolutely, we're here to support you, but you are not, this is a risk you had yesterday and last year and the year before. And that just because we know about it, it doesn't mean that all the cancers are about to happen. And as I said, I have to say that out loud to myself. And I say that out loud when I'm working with people all the time, because it's so easy to get caught into this, worry about the risk, which we are all completely alert to, but to kind of take a breath and say, okay, you don't have to run out and have all these surgeries tomorrow. We can think through what makes sense step by step.
So can I just add to that? I agree with everything that Julie just outlined. The other thing that we would take into account as we're advising would be family history. If we're seeing a lot of young ovarian cancers in the family, we may modify certain things, in terms of recommendations. Same with the breast cancers. And it's always important to think about, you don't have to have a mastectomy, because sometimes when patients are tested, they may be given that information. And we have options for breast cancer risk management. It's either screening and then the option for risk reducing mastectomy, right? With screening, we've done long-term studies to show that we are able to detect the majority of the cancers early. So there is no need to jump to a mastectomy. And I think that is really important at the time of diagnosis, because this is an irreversible procedure and you need to really put thought into, is this something you need to do? And no one should be pushing anyone to do this. And in the context of a breast cancer diagnosis, again, like Julie said, there are options here. And part of it would be taking into account, well, how old were you when you had your first breast cancer? That's going to tell us what is your risk for the second breast cancer. And speaking to, well, how effective are these risk-reducing procedures? With ovarian cancer, 90 to 95%, right? Over 90% were able to prevent ovarian cancers. With breast cancer, again, the number is somewhere around 90 to 95% risk reduction for a new breast cancer. With ovarian cancer, again, some of the new information, or information that's been out for a while, but when you remove your ovaries, there may be additional benefits to breast cancer, reducing the breast cancer risk, right? The fact looks stronger in BRCA2 versus BRCA1. It's questionable now. Like there is some data that's bringing into question, does it reduce your breast cancer risk in BRCA1? Kind of makes sense because BRCA1 carriers tend to get triple negative breast cancers. So again, what I would say is go to someone that knows this information. I think that is critical because, you know, back to your point, Elise, a little while ago with, you know, other genes like PALB2, CHEK2, ATM, I saw a patient in clinic that came to me who with an ATM mutation yesterday, who was advised to have, you know, sent to a surgeon for a bilateral mastectomy and got pancreatic screening through an MRI. Both of those are wrong. And she sought out our clinic to get the right information because with ATM, the lifetime risks are 25 to 30%. This patient may even be lower because there was no family history of breast cancer. And her 32-year-old daughter was also tested positive, given the same information. So I cannot emphasize enough how important it is for everyone to kind of empower themselves, go on to NCCN, pull those guidelines, go to a provider that knows this information and it does it day in and day out. I think there's a tremendous opportunity on the primary care side to identify, because again, this patient that I saw had a strong family history of pancreatic cancer. 2 uncles had died of had pancreatic cancer. One was deceased, and then father had aggressive prostate cancer. So it actually fits ATM. It was a good pickup by the provider. But then once you get this positive result, what I would encourage even providers to do is send patients to someone who does this day in and day out, because I just worry with these larger panels that patients are getting overtreated. And, you know, we don't want to undertreat patients in terms of cancer risk management. We also don't want to overtreat patients, especially for procedures that are irreversible, right? That they didn't need. With pancreatic cancer screening, we don't do pancreatic cancer screening with an abdominal MRI. It's MRI, MRCP, staggered with an endoscopic ultrasound. So even the pancreatic screening this patient was getting was not correct. So go to someone who knows what they're doing, empower yourself, go to Force. They have fantastic information. You know, there are other information feeds through our inherited cancer registry. Again, we push out information as it comes out as well. There are many organizations that are doing it. So I do think it's important to empower oneself with information.
So I think the answers you've all given are so comprehensive, and we are coming up time where we're going to wrap here. But I do want to say, just as a constituent myself, it is just so important for us to hear that we are moving in a direction of individualized care relative to a plethora of risk factors and genetics taken into account. I do want to make sure we have time for one more question, and I do want to make sure we address it because it's lighting up in our chat. And this is kind of a piggyback of what you've just been talking about, too, about risk reducing surgeries for ovarian cancer. We do have a number of constituents asking about if you could just provide more information and color around salpingectomies as an option for reducing ovarian cancer, as opposed to an oophorectomy or a total hysterectomy in the short term.
Okay, so here's the issue, right? So several years ago, based on the scientific literature, what we were able to figure out, we think, is that most of the ovarian cancers originate in the tubes. So that's where this idea of salpingectomy came up. The issue here is it is not a proven surgery to address ovarian cancer risk. I think it should be done in the context of a clinical trial, ideally. Is there potential to reduce ovarian cancer risk? Yes, there is. But I don't think that should preclude a discussion of like having the ovaries removed. Now, you mentioned hysterectomy. Again, with BRCA1 and BRCA2, there isn't a huge risk for endometrial cancer. With BRCA1, we think that there is, a certain aggressive form of uterine cancer that you may be at slightly higher risk for, but that's not enough to push us over to say, oh, all BRCA carriers should have their uterus removed. uterus is removed. That's not where we're at scientifically at this point in time. So salpingectomy has potential to be an interim solution if you're not willing to have your ovaries removed. It should be done in a clinical trial. We need to figure out how it works, because I think it would be wrong to think that you've reduced your risk and you're not going to develop ovarian cancer by just having a salpingectomy. Marc, you may have stuff.
No, I completely agree. We agree. And in the UK, we're doing a study looking at this. I'm a bit nervous about it, to be honest. I think if you've got a BRCA1 or BRCA2 pathogenic variant, you should probably go for the full oophorectomy.
Excellent. Thank you very much for speaking directly to that question. At this time, we have come to the end of this panel. I just want to take a moment to thank all of our panelists for providing such an informative presentation for us here today. I want to thank everybody who's written in for your questions. They really helped us to, I think, talk about a broad sweeping number of topics here, but also addressing really acute questions that constituents have on a daily basis. So now is a good time to just thank our sponsors for bringing this programming to you. I want to remind you to please fill out your individual session surveys that you can find in the description of each session. Continue to access all of our sessions that we have for the remainder of today and tomorrow. Download our resources, go to the FORCE website. Also, please visit our exhibit hall and download the resources that our exhibitors have there and engage with them as well. This conference is for this community, so we've really worked very hard to make it as robust and informative for you as possible. So at this time, we are going to leave this panel, but we encourage you to continue to engage today. Thank you so much, everybody.